I'm currently assistant professor teaching a stream in the Department of Mathematical and Computational Sciences at UTM since July 2021, last year. Before that, I was a postdoc for 2 years at Sick Kids Hospital from 2019, July 2019 until July 2021. And it was 6 months after my postdoc position that COVID-19 hit, and basically all of our activities, our research, our discussion with other postdocs were, and my peers and lab members were all about pandemic, how to track the data, monitor them, and some projects about how to allocate the resources that my peers they have been working on. And then when I started here, I decided to basically submit some proposal about my research projects that Rima just mentioned. So, and I realized there is a lecture me about presenting, and I eagerly accepted to present some topic about what I had been doing over the last 2 and 3 years, whether during my postdoc as well as my current position. So in this seminar, I'm going to briefly talk about the progress of COVID-19 pandemic in the first year, so you can see how it actually the virus spread globally as well as here in Canada. Then I talk about the statistical modeling that we use to to basically use them in order to control and analyze the data from infectious diseases, particularly COVID-19. And finally, about the vaccine efficacy that I also presented in my current job, and the Pfizer data, and why they say, for example, 95% efficacy of the vaccine. We talk more about the details in both statistical language as well as what we have in the papers in the top journals. So here, the outline. First, I talk about tracking the global outbreak, then the statistical methods for modeling infectious diseases, and vaccine efficacy at the end. So, as you know, since the start of the pandemic, researchers around the world and the public health centers, they have been collecting, tracking, and monitoring the virus progress in order to slow down and control the spread of the disease, and also to allocate effectively the resources, let's say hospital beds and ventilators and other things, and also give the best advice to public. So let's just first, before we look at the spread of the disease in the first year, look at some important dates at the onset of the COVID. It was in December 2019 that SARS-CoV-2, which is the virus that causes COVID-19, was first identified. And in January 9, 2021, a few weeks later, World Health Organization announces that mysterious coronavirus-related pneumonia is in Wuhan, China. And then just a few weeks again later, World Health Organization issue global health emergency. A few days later, in February 2nd, global air travel, if you remember, was restricted. And the next day, the US declared public health emergency. And finally, on March 11, the World Health Organization declared COVID-19 a pandemic. So these are the important days that we had until December 2021, when basically vaccine was found, and it was actually distributed to countries around the world. So if you look at the the track of the COVID-19 in a daily confirmed news, you see that what is happening in January 23rd, 2020, we have what we had around 100 cases here around in the East Asia, and then it actually rapidly spread to other countries, including Iran and Italy, more rapidly in Italy. And then in March, we see that it actually came to North America, especially in the US, and even and as well as Canada. And in other countries as well, more or less. And we see that it spread rapidly in Canada, US, and around the world. And then thanks to, basically Canadians' effort, they were able to slow down this spread by wearing masks, staying home, and the social distancing and other basically advices. So we see that in June, we compared to May, they have slowed down the spread of the data. And by the way, these data were collected by Johns Hopkins University, which is one of the top universities in the world in health and in medical sciences. And then again, in July, we see that still they were able, Canadians, to control the spread, while other countries, the cases were high. And then starting September, we see that again, the cases went up again in Canada, and then through October, and then November again went up all the way to December. So this was about the spread of the daily cases in Canada and around the world. And this is when vaccine found and then they were distributed in Canada and around the world. And the first shipment arrived in Canada on December 14th and distributed and rolled out around the other provinces and territories. So I'm going to talk about specifically about the tracking daily cases in Canada, as well as death, hospitalization, ICU, not just in the first year, in the last 3 years, that we see that the spike that we had the earlier in 2022 in January because of Omicron variant, that was a spike, and before that we also had in pretty much in every few months, mostly in the second half of the year, or in the basically spring, fall and spring, we had more cases. The blue curves and is about Ontario, which is the biggest province. So this actually high number is not surprising. And also about the Quebec is the second biggest province, and so on. So this is about the number of daily cases, although they are in the first phase, because the first at the beginning, based on the doctors, it was more basic. In the more recent one is more contagious, although it was not let's say Omicron was not more serious the symptoms, whereas at the beginning was less actually contagious but more serious the symptoms of the COVID. So then we had the number of hospitalization over the last 3 years. If we look at this again, at the beginning of 2022 and the Omicron variant, we had a spike, and pretty much over the last 3 years there was up and down, and in different times that we had. Then we had ICU data. That again, this data, by the way, were collected and analyzed by the University of Toronto Center. And we had again the Ontario, which is again the biggest province. We have the highest number is about the ICU data, that at some point we see that we had more than 750 ICU, the number of people in the ICU in the province, in this province. So the numbers are quite shocking at some point of we see, and that's part of the purpose, to monitor and track the data, to allocate the limited resources such as ventilator and the hospital beds and health workers. So we remember that at some point there was a shortage, and how to effectively and efficiently allocate those resources to other hospitals across not just province and perhaps the entire country. So this was just some illustrations and the plots and the curves to see how the spread and the virus spread globally as well as in Canada over the last 3 years. So in the second part, I'm going to talk about specifically what actually it's my expertise about statistical methods for modeling infectious disease. Obviously, disease and their symptoms is not my expertise. And we as a statistician, the data that have been collected, we just analyze them and then just provide them to doctors for the best advice that how they can actually control and how the efficient way to roll out vaccines and so on, and basically allocate the limited resources that they are available in an efficient way. So the models that they use in epidemiology are called compartmental models, that they try to predict how the disease spreads and the total number of infected, the duration of an epidemic, and to estimate the various parameters such as reproductive numbers. And I currently have a student to work on these models and is going to do it for her undergrad projects. And I'm so also interested to learn more and to do more and to see and to analyze data, because the data are out there and we can use them for predictions and to also to show how different public health intervention may affect the outcomes of the epidemic. So again, it's up to the top doctors to actually see which one is best and to provide the best advice. And in specific models that they use compartment, it actually dates back to maybe 100 years ago. It's not just a recent one, although it has become very important recently in the last few years to analyze the data. And I just want to talk about some simple and basic models, but the models might be oversimplified, but they can use them to build a more complex model that they are very close to reality. So the most simple, the simplest model, it's called the SER model, which stands for S for susceptible, the number of people who are susceptible in a population, I for infected people in a population, and removed or recover for the number of people who are either they have recovered or they have passed away because of the infectious disease. So we use SIR for susceptible, I for infection, and R for recover. And people progress between these compartments, that they first are susceptible, then they get infected, and then they recover. And they may also die because of that. But for now, we just assume that people actually, they are susceptible with the rate beta, they get infected, and with the rate gamma, they recover. So this is the most basic model that we can think of, and it's called the third model. As you see, it's almost 100 years that Kermack and McKendrick introduced these models, and this is a curve that as time goes, we see that the number of susceptible people, T, drop, and people actually get infected and then recover afterwards. So one assumption that we make here is that the rate of the people who die because of the infectious disease is very small, the rate, and almost all people will recover over time. So we can actually solve this model by using just ordinary differential equation, some model that mathematicians they use in differential equation. And the student I mentioned earlier who's going to work this is taking a course on this, differential equation and how to solve them. So we use them to solve the model. The rate of susceptible is minus beta SI. Beta, as I said, is the transmission rate, and beta SI is going to be, the number of susceptible individuals that become infected. So this rate is going to be negative because the number over time, the number of susceptible will actually decrease and the number of infected will increase. And gamma is the rate of recovery rate, and gamma times I is the number of infected individuals that recover per day. So 1 over gamma is the reverse of infection. The reverse of the rate is always the period and that takes for an individual to remain infected. So this is, again, by using some differential equations method, we can solve this equation and estimate the parameters. So as I said, the SER model is the most basic model, but we can extend this to, basically estimate for, different infectious diseases. For example, the SIS model is the case that we don't have recovery. Once people infected, again, it is possible to, they become susceptible, such as cold. When people recover, it is possible to get cold again. So some infections, such as common cold and influenza, do not confer any long-lasting immunity. So there's no immunity when they cover. They might actually, again, get infected to the disease. We also have the SIRD model, in which the susceptible infections recover and disease. So people, when they get infected, again, although the rate is small, they, die because of that. And then in this case, there are two rates, and the bigger rate is for recover, and the smaller one for the disease. And finally, we also have the SIRV, in which we have also recovered vaccinated some portion of the population. They become immune because of the vaccine, not because they got infected and they recovered, so they got natural immunity. So the list actually way longer than this. They are more advanced, let's say, people who exposed to the virus, but they don't get infected. This is more realistic because we know that not everyone who is exposed to virus would actually get immediately infected. So this is a diagram, again, for vaccine, that as you see, some susceptible people susceptible to the disease, they get immunity and by vaccine. Others, they get infected and they become immune. And then afterwards, after infections, they might get infected again with different rate of vaccine and the rate of infectious, which is beta over n. So again, they use tools that they use in mathematics and statistics to analyze the data and estimate parameters. And as I mentioned earlier, to predict how the disease spread, the total number of infected, how to allocate effectively the resources, and how to roll out a limited number of vaccine to to the people who are more vulnerable, and they are more prone to, and they are more at risk. So let's look at the case that there is a vaccination at birth, such as polio and measles, that people can get vaccine when they are toddler. And then we're in this specific, diseases, infectious diseases, we can use these differential equations to solve them. So you see that here, people with proportion P, they get the vaccine and then they get they become immune to infection. And then vaccinated people will avoid the susceptible class, so they already have the immunity. And then again, there is room always to improve this model by basically adding more parameters and models. And so that's what we actually intend to work. And then try to relax some of the assumptions that they might be strong for this, and analyze data based on the new models that we have. So here, mu is the rate of vaccination, and P is the proportion of people who actually get the vaccine. So in the third part of the this talk, I'm going to specifically talk about the efficacy of mRNA or Pfizer vaccine that actually was published in December 2020 in New England Journal of Medicine, one of the top journals of medicines, and it was about the efficacy of the vaccine. So before that, I want to actually give you some background about the guideline for clinical trials that the top health center in, for example, the US, FDA in Canada, Health Canada, before they basically approve and grant approval, or in case of public health emergency, uh, approve the and authorize any vaccine, they need to carefully review all the data and all the clinical trials need to be conducted very carefully. Specifically for any clinical trials, there are three phases, and the first phase they focus on safety of the vaccine for healthy people without any precondition and any disease. In the second trial, they expand the recruitment to other demographic group, and there's other let's say different races and different genders, different age groups, and so on. And they look at the thousands of people to look at the safety and efficacy of the vaccine. And in the third trial, they recruit again thousands of participants to measure the efficacy of the vaccine. So specifically, the basically in this paper, which was published by Polak and his colleague in 2020 about the efficacy of the mRNA or Pfizer vaccine. It's the study was a multinational in phase 2-3 and the placebo control observer blinded randomized trial. So those who actually attended were blinded and assigned to two groups, and then the objective was to evaluate the safety and efficacy of the BNT162b2 vaccine or Pfizer mRNA. So they basically assigned to these two and receive one of these two, either the vaccine, Pfizer vaccine, or placebo saline, and two doses in 20 days apart. So 36,523 participants from different, basically demographics groups, without any evidence of prior SARS-CoV-2 infections, were assigned to these groups. They were randomized, and then without any evidence, in 7 days after the second dose, they found that 8 people tested positive in a vaccine group, whereas 162 people in a placebo. And they concluded by the method I will talk about shortly that the vaccine has efficacy of 95%. So with a credible interval 90.3 to 97.6%. So this is 7 days after the second dose. So how they actually arrived this number and they how calculated, they use a statistical method that I'm going to talk about. So this is a table that we only talk about, the first row, it's about the people without any evidence of infections before. So we use this data for data analysis. The lower one, there are 40,137, and they include both people with and without prior evidence of infections. But we only basically analyze the data, with the first row, and for the people who without any evidence of infection. So, and the number, as I said earlier, there are 36,523. So this basically a study for people 16 years or older, and they were healthy and had a stable chronic medical conditions. And the paper was published in 2020 in Journal of England Journal of Medicine. So we have the data here that the vaccine group placebo tested positive or negative for vaccine. There are 8, and the other 18,190 they were tested negative. This is the total, which is fixed, and the total number of people who assigned to placebo is 18,325. 162 of them they were tested positive, and others they were tested negative. So this is a topic, and this is a question for a student the last year in statistics, to analyze data, or by a statistic to analyze the data and to find their, let's say, the proportion of the people or the odds ratio of the this number vaccine over placebo. So the objective is evaluate the relationship between COVID positive, negative, and the vaccine and the group, which is either vaccine and placebo. And we assume that they are independent, which means that basically the outcome of the vaccine group for one person would not actually influence the outcome from the placebo, because they were randomly assigned them, and then the completely independent. So they, as I said, the data were collected across subgroups, but we only talk about just one basically treatment, vaccine, placebo. We can analyze them for other subgroups, but here I only focus on the efficacy of vaccine compared to placebo, and how to analyze by the statistical tools that we have. So we can assume that we have a binary response here, and because it's either tested positive, negative, so there are two outcomes. And then this is going to be basically each of these row a binomial distribution, because the number of people who are assigned to each group is fixed, and the number of people who is going to be positive is a random variable and follow binomial distribution. One of the standard distribution you may have heard if you actually took any stat course before. Then these two groups are independent, each of them binomial with parameter mi and pi, pi I, or pi k, and k is the group. So we can actually find the estimate the parameter. Before that, I'm going to briefly introduce the notion of odds, so which may you hear in a daily conversation, that the odds of one event is the ratio of the respective probability, basically the probability of winning divided by probability of losing, let's say, a game. So that is going to be the odds of the game. And the odds of positive COVID for a vaccine group is the probability of testing positive divided by testing negative for a vaccine group, whereas the odds of positive COVID for placebo is the probability of testing positive with placebo divided by testing negative, and the chance of testing negative. So the ratio of these two odds, it's called odds ratio, and we can use it to actually get that 95%, which was the headlines of the news in December 2020. So the ratio is it's called the odds ratio, and if this ratio is almost 1, then we can just ignore it, and it's called the risk, relative risk, another measure that they use to basically describe to compare vaccine and the placebo. So in order to estimate this, if you heard about the likelihood function, is one of the maximum likelihood method, is the method in a statistic to estimate parameters. Basically, they collected based on the collected data, they construct the likelihood, which is the probability distribution of the data, and then they maximize it again by mathematical tools, and they can show that again the estimate of the chance of test positive for vaccine group is the number of people who are tested positive divided by the total number of people who are assigned to vaccine. And similarly, the estimate of the chance of the people who are tested positive in placebo group is the number of people who are tested positive in placebo group divided by the total. And as I said, go back to this formula and replace those parameters with their estimate and get that number, which is 95%. So this, again, in the paper, they also they compare, the efficacy of the vaccine as well as the placebo with one dose. And you see that over time, days after dose one, the number of cases or the cumulative incidence percentage for the BNT162b2 Pfizer vaccine is quite, flat, whereas the other one for placebo, it keeps increasing. So that's for also some of other results. And as I said, they also collected the actively recruited, participants from various demographics, from different sex, different race or ethnic groups, such as white, black, or African American, Asian, Native American, Native Hawaiian, and Pacific Islander, and others for countries, 4 countries, including Argentina, Brazil, South Africa, and the US, and for age either less than from 16 to 55 and bigger and more than 55 years old, and for age as well as the body mass. And also, I believe there was a table about the precondition if they had diabetes or, heart disease and other diseases. So this is another one about the efficacy in other groups that we will not show how to analyze them. They require, especially when the number of group is more than 2, such as age groups or let's say race, and they require more advanced statistical methods. But there are tools there to show that in other subgroups we also have that efficacy. So this paper, as I said, was published in the Journal New England Journal of Medicine, one of the top 3 journals in the medicine by Polak and his colleague 2020. And it was part of my presentation for my current positions. And so one of the concern about the vaccine was about the side effects and what happens after the vaccine. That if you remember, there was a big discussions about some rare side effect that is a very serious one, especially for AstraZeneca. But here for Pfizer vaccine, here are some of the results, that were collected, the data collected from vaccine, that 83% of the people who got it, who received the vaccine, they had some pain at the injection site. These are mild, side effects after the vaccine, so they were not that serious. 14% in placebo, they had pain. 47%, whereas compared to 33% fatigue. 42% they actually had headache. 34% headache for placebo group for people from between 16 to 55 years, and for more than 55 years, then the numbers again, 71% pain at the injection site and 9% in the placebo group. So 34% in fatigue for a vaccine group, 23% placebo, and for a headache, it's 25. These are top 3 side effects. That there might be others, but these 3 are more prevalent and the more common side effects after vaccine. So they are mild, and there were just maybe in 2 days at most. And then for the more serious adverse event, it's very rare. It's 0.6%. It's 6 people out of 1,000, and they had some more adverse. But again, this is not about the blood clot and the other issues. And the number, as you see, for both are roughly equal. So both the vaccine and placebo or in conclusion, the vaccine is safe and effective, and also the reactions, severe reactions after vaccinations are rare. So these are the basically shows that Pfizer vaccine was safe, effective, and the symptoms and the side effects were rare. And then finally, I'm going to talk about the vaccination rollout across the globe as well as in Canada. That we actually show some of the vaccination progress in this actually map. You see that the people people who receive at least one dose in Canada, specifically 87.4% receive at least one dose, and across the globe that you see that based on the number that we have the percentage of population receiving at least one dose, you can actually compare them. And if you want in different provinces, you see that the vaccine coverage for the first dose, the number is more than 90% in different provinces and territories. We can compare them and see since actually it's started from the beginning of 2021 all the way to right now, the fall 2022. And also about the second dose, so the number is lower. The second dose is around still 80%, and again you see that by the summer 2021 we had 75% of the Canadians received the 2 doses of vaccine, one of those confirmed and approved vaccine. So here are some of my references that I use, especially for the first 3 for analyzing infectious diseases and the cell model and some of the more complex models that we use. And we intend to use them, although some of them are pretty old, in this one 1927, but the most recent one 2021 specifically for COVID vaccinations and how to allocate the resources to them in our project. And finally, Pollock and colleagues in the paper I basically use for a study for the efficacy of COVID-19 vaccine mRNA and Pfizer. And thank you everyone for your attention.
Thank you very much, Professor Jazi. There's only one question right now in the question and answer box, so I'm going to remind everybody, if you have a question, you can place it in the question and answer. You do that at the bottom right hand of your screen. There's a little question mark, and if you click on that, you can ask a question. But the question that's there right now is, on behalf of the Experiential Education Unit, thank you for delivering an insightful talk. And the question is, have you been able to share the findings of your research among the medical community or more broadly?
Thank you for the question. So when I was a postdoc with some of the lab members, so we were been actually using some statistical method to track and to basically use some apps such as Shiny app to illustrate the tracking and then share them. And it was out there, public. I don't know if they've been using that, but there were other groups that are more seriously working on them and they were providing to medical doctors. But we've been actually working them and made them public. Those basically plots and analysis. I don't know if they have used, but no, I personally didn't use. But we've been working in the lab. Other basically researchers at Sick Kids Hospital working specifically with province to allocate the resources, ventilators, beds, and the resources. But our project was to track the data, use those app to illustrate the day and see the the progress of the disease. And so in terms of publication, we've been working on this, and I have a student and I intend to do this, but I did not provide it to the doctors. So I believe that they have their own researches specifically that they can provide them.
Okay, we have another question. Is there any research comparing infection rates for people with a fourth or fifth dose versus those with 3 doses or less?
Uh, I actually read that, yes, they have actually, and they released the data that, they compare them. It's not actually off the top of my head, but they compare, let's say, the efficacy of the, vaccine for hospitalization compared to immune and natural immunization. So, yes, they compare the third and fourth. I don't have it here in my report, but about the efficacy, I don't know about the fourth, but I have seen some data. They don't have it here, that about the third dose, mostly for to reduce the number of hospitalizations. So because yeah.
Okay, there aren't any other questions there, but I'm going to ask you a question from a very layperson point of view. Studies are finite, but after the study is done, things still need to be tracked, right?
Yes.
So how can you tell us how that happens?
To track them. So this, again, in different phases. First, they collect the data maybe in hundreds people. In the first phase is just to check for healthy people to ensure the safety of them, and then they go and do it for thousands of people, as we actually had in the second phase, 36,000. And then again they do for other subgroups, for because over the time people raise other concern that, let's say, people who are, they have some diseases, they had heart diseases, is it safe for them to have this vaccine or not? So they keep actually updating, collecting data for that subgroups, and then see the results. So initially, because it was for emergency use, they, after the second phase, so they authorized the use of vaccine. But over time, people, other from other, demographic groups, and other people with other pre-existing condition, some, I remember that at some point, some they had concern about the pregnant people, that whether it's safe for them to, get the vaccine or not. So these are actually, these questions require, a study again and again. So I'm not sure I answer your questions, but yes, I mean, this basically a study was done in 2020, and because if you remember, there was a, you know um, emergency, and there was actually, because the number was high, number of hospitalization, so they just authorized them to use. But for other subgroups, they keep actually studying and then collecting data from other subgroups.
Yeah, I think you've answered my question excellently. The,
Thank
the tracking just goes on and on.
you.
It's so
Yeah,
important to
exactly.
keep on doing it. Okay, we
And
have someone.
also, if I may add, to also provide the best advice, because again, they still, even I checked today that in, let's say, Ottawa and others, it is they tracking the number to see that basically when, to provide the best advice, let's say, to wear mask in indoors, so the cases are high, so public know what's the best things to do. Right now, let's say, at this time the cases are high, so better in the, closed door, and in crowded places wear their mask. So they provide the best advice to doctors based on the, the data that they have, you know pro, give the best advice.
Thank you.
Right.
I'm going back to the question and answers now. Could you expand on potential developments regarding the next generation of vaccines?
So this is not my expertise about the, vaccine development. So this is question should be for doctors about the, vaccine. So my role as a statistician to, to analyze the data and then provide the doctors, and they, decide about the, so vaccine specifically development is for the doctors and their experts. And but for me as a statistician, I'm not really knowledgeable, and so I can pass it on. So for doctors to answer about the, future, they will, vaccine. But as a, personal opinion, it could be, more effective, more actually and safer. Vaccine should be with the lower side effects. We show some result from the, some mild side effects, and more than 95% efficacy of the vaccine should be in the future, in my perspective. But again, I'm not expert.
Thank you for doing your best there. The next question is about lower side effect percentages from the vaccine in those, and I'm not sure what the sign is, either less than or greater than 55 years of age.
Could you repeat it again? The lower?
Why do you think either greater than or less than 55 years old individuals have lower side effect percentages from the vaccine?
I think they are more probably vulnerable. So those who are more than 50 less. Let me double check my numbers from the paper. That's a good question. Yeah, thank you. That people who are, lower 55, for example, those are mild, right? So mild, let's say for pain, it was 83%. That's compared to, I never thought about this, but thank you. That's a very good question. That compared to people who were above 55, I can share and we look at everyone can see. I think that's a great question. I never actually basically thought about that, that people who are younger, they have actually, but if you compare, let's say, mostly again, for fatigue is higher compared if you, I don't know if you can compare these two groups together, but right, yeah, that's a good question. So I think I need to think. It's not off the top of my head. That again, the result is from the paper that people who are younger, the percentage are are higher, 83, 71, and 47. So this is something I think I need to dig more into this, the reason behind that. But that's a good question. I mean, we actually, the first thing comes to our mind is just to be opposite, right? That people who are older to have more basically side effects. And but yeah, right now I don't really know. So why this happened? But that's a good question. Thank you.
It's a very interesting observation, yeah.
Yeah.
The next question is, Simon is wondering if you have any forthcoming publications in this field, and if so, what areas will you explore in these publications?
Yeah, we haven't submit, but intend to in the topics of cell models, that analyzing models by for vaccinated data, because we have the data, and so for the student we intend in the next few months submit some work about the how to use a differential equation, because the student has that knowledge in the course, and she's taking, and I also teaching a course in this semester on stochastic process, although this basically is about deterministic models, but we use the same tools about solving differential equations method. So we intend to expand this and then apply it to the data, vaccine data. So yeah, my mostly work which is relevant to this is to use a statistical model, differential equation, to estimate those parameters, and then by by building more complex model than what we currently have. So and then this is my basically current project.
Okay. We want to continue the conversation about over 55s having lower side effects. A question about that is, could it be because the baseline level of pain, headache, etc., is higher for the older group?
Right, yeah, that could be the answer. Yeah, I think that's a good point. Yes, I think it should be actually one of the reason. Again, I never thought about this. This is right in the paper that they released, and they might actually use a different baseline. That's right. That, and also could be other side effects. These are three top side effects that we have here. For others, could be actually higher, because we know that these are not mutually exclusive. People might have more than one side effect afterwards. I myself had pain as well as a little bit headache for a few hours and fatigue, all of three. And so there might be others that those basically percentages for older people would be higher. But that's interesting. Yeah, that could be a possibility. Again, right now I don't have any solid answer for this, but I need to think, and that's a good, interesting question.
That's why it's so important to show your research because
Yeah,
you get other
exactly.
people
So
asking you
thank you.
questions about it. Yeah. Going back to the chat, is there any data that you are aware of that delineates outcomes based on vaccine strain? Example, the original vaccine versus the bivalent shot versus the shot formulated for the Delta variant?
There should be, but because again, I'm not working on the vaccine currently. I don't know. I haven't known, but I suppose they have worked on different variants, Omicron, Delta, and they have compared them. Whether each of those vaccines that they have been approved are more effective, and then they can basically control that and the virus and those variants. But yeah, I haven't looked at it recently about this because again, I basically use this paper to for one presentation specifically about the efficacy of vaccine last year. But I've been mostly using the models for differential equation that I've been working. But Mm, yeah, I suppose there are, but I don't actually know right now specifically any papers because I haven't read them.
Okay. The next question, what are the strengths and weaknesses of the model you presented? And are there blind spots or cautionary notes that the viewer should be aware of?
Yeah, that's a good question. Thank you. For these models, again, some of the assumption could be strong and not really realistic. For example, when we talk about the cell model, the most basic one, we don't have, let's say, the case that people, die after they get infected. It's just they recovered right after. It could be, let's say, for a cold that it is very unlikely that people die because of cold. But again, for a cold, we know that people again they get they become susceptible, as we had in the SIS model. So some of them again, because they are very old, the models are oversimplified. But there is always a room to again to use the methods to build more advanced and more realistic models. So the good thing about them that the theory about them we can relax the assumptions that they are there, and they use more advanced mathematical statistical methods to estimate those parameters. And then basically this diagram that we have make it more realistic and close to realities by adding other assumptions. So we have as I said, the long list of models about exposure and about the vaccine, that whether this vaccine that we have, it is possible that people get the vaccine, but they don't get basically protections, right? So these are all the assumptions that, let's say, for these models, we uh, don't account for. But if we basically use a models with more parameters, we can take them into account. So upside is that they actually basic and we can build on them. And the downside is that again, oftentimes some of those assumptions are not realistic and we need to be aware of them.
Thank you. That's the last question we have in the Q&A, but people can pop in a last question at the last minute now if they want to. Give them just a few seconds to see if anything else pops up. The beauty of a lecture like this is you get to hear what people want to know too. So it enhances your study
Yeah,
as well.
exactly. Also, I enjoy, and that's what I like. So my main responsibility is teaching, and I believe that teaching is the best way of learning. And when I presented as one of the audience, mentioned about the, the side effect, always learning something, and it's rewarding that, something they never actually paid attention. So they bring it up, and then we can actually think about it for future research and study about the models, about vaccines, efficacy, and why that number is higher for younger people.
Yeah, and a last question has popped up. How have the statistics for COVID-19 differed from the statistics of other or previous pandemics or viral infections?
They use the same in terms of cell models and more advanced. Again, they are the same, but that's a good question, because if for diseases such as, let's say, infectious such as cold, we need to use a different model compared to, let's say, measles and polio, and that they are also infectious diseases. We use the different models because the nature of those infectious diseases are different from COVID. For COVID, so there are different variants. For example, there are actually, I learned today that there are hundreds of variants there might be. So this is SARS-CoV. So it's part of that virus that causes COVID-19. So in nature, this kind of infectious disease, there are differences with other, let's say, influenza as well, and also measles and polio. So because of the differences, we need to make different assumptions, and then the models will be different. So yeah, for the statistical models, but in terms of the tools that I use, let's say for odds ratio and the models that we use, no, they are the same. But for the cell models and differential equations, for different models, depending on the nature of the infectious disease, we need to choose the proper model. Thank you. That's a good question. So in terms of the statistical methods, estimation method, they are the same, but about the cell model and those compartmental models that I introduced, including the most basic, the cell model, we need to actually change them, based on the the nature of the infectious disease.
Okay, thank you very much, Professor Jazi, for your presentation, but also for the questions, because it's often a very interesting time. I think we're done with asking questions now, so we are done. I hope that people consider joining us for February 7th for our next Lecture Me program. Thank you all for coming tonight. We do invite feedback, so if you're interested in giving us feedback, the address is there on the screen. We'd love to hear it.